Welcome, everyone. So exciting to see such an enthusiastic turnout for a chat about funding for harm reduction. My name is Naomi Burke-Shye, and I'm the Executive Director of Harm Reduction International. And I am so excited about this topic. I am dialing in from Melbourne, Australia this evening. So it doesn't really speak more than that. Harm Reduction International has been monitoring the funding landscape for harm reduction for more than 15 years at this point. We know that to ensure that we can get life-saving services to people who need them, we need to really understand and get to terms with what it means to adequately fund these services. We're really excited about the Global Fund replenishment of $15.7 billion US, the new focus on communities and the Global Fund strategy, but obviously we did not reach the replenishment target. And so it's really critical that we have this conversation to begin to grapple with what that's going to mean for harm reduction. When we published our latest global mapping of the funding landscape in 2021, we proposed 4 strategies for grappling with the vast crisis in funding for harm reduction. We said, firstly, we need to optimize and maximize the existing funding streams. And that's what today's webinar is all about, making sure that the global fund funding that is available to us, we make the most of that. And that's everything from making sure there's solidarity and collaboration between key populations and criminalized groups to ensuring that when we do need a specific service funded, it goes into a global fund grant proposal. The second thing we emphasized was the importance of ensuring transition plans were in place and ensuring that our focus in the medium term really goes to domestic resource mobilization. And that's something we work on more broadly with country partners. National budget advocacy is critical to sustainable funding of harm reduction in the future. Thirdly, we talked about the fact that in some particularly hostile environments, in some crisis contexts, we're always going to need donors to step up and to be there, in the long run. And we've got Ganna Dovbakh from the Eurasian Harm Reduction Association here to speak with us today, someone who knows a crisis context particularly well. And then our 4th strategy or pathway to funding for harm reduction was really about looking at big new ideas. Where are the new funds going to come from? What are the new funding sources? Can we redirect funds from other public spending? Can we ask for greater accountability in public spending to spend on things that result in greater health outcomes, greater social justice outcomes for the community? I'm really excited to welcome you all here today. Even more excited to have interpreters with us. So I encourage everybody to speak at a pace slower than which I have set so far. The webinar will be translated into Russian, Spanish, and French, and we're making those recordings available after the event. Thank you very much to our translators. And finally, in terms of housekeeping, please, we welcome comments in the chat. This is a webinar, this is a meeting format, not a webinar format, so just put your interactions in the chat, and we'll get to a Q&A session at the end of the event. And now I'm really pleased to hand over to Harm Reduction International's Sustainable Financing team, our lead, Catherine Cook, and our researcher and analyst, Gaj Gurul, to take us through the webinar. Thanks, guys.
Thanks, Naomi. Thanks for those introductory words. And thanks, everyone, for joining us for this discussion. We've got a really brilliant panel of speakers who'll be giving us their insights on the Global Fund replenishment outcome and what it means for harm reduction and what can be done to support harm reduction in the 2023 to 2025 grant cycle, otherwise known as NFM4. But before introducing the panel, I just want to give a little bit of background on harm reduction funding and the landscape, which will lead us into our discussion with a sense of the crucial role that the Global Fund plays within this. So, harm reduction interventions for people who use drugs, such as needle and syringe programs and opioid agonist therapy, are cost-effective, protect against HIV and hepatitis C, and they save lives. And that's not just the view of harm reduction advocates. We have evidence-based guidance from the UN and WHO which call for harm reduction implementation. The 2021 to 2026 Global AIDS Strategy, signed up to by governments around the world, states the need to intensify and redouble efforts to scale up comprehensive harm reduction for people who inject drugs in all settings. Yet the global provision of harm reduction interventions is critically low. At last count, 92 countries around the world have at least one needle and syringe program in place, and 87 have at least one opioid agonist therapy program. But many countries still do not have priority harm reduction interventions available, And of those that do, many are small scale and often not available in prison settings. Last week, we heard from UNAIDS that while key populations make up 70% of new HIV cases, only 3% of funding is allocated towards key population programming. There's a 25% shortfall in funding for the HIV response overall, but for harm reduction, this shortfall is 95%. Investment from international donors and governments in lower middle income countries totaled 131 million in 2019. That's just 5% of the 2.7 billion that UNAIDS estimates is required for an effective response. Domestic budgets are funding harm reduction in some countries, but this lags far behind domestic funding of HIV responses more broadly. Very few governments are funding comprehensive programs and even fewer at scale. In many countries, there are no policies or mechanisms to directly contract community and civil society organizations as service providers. Government investment in harm reduction needs to increase, but building the political willingness required is a long process requiring strong and sustained community-led and civil society advocacy, which needs international funding. International donors remain a crucial source of funding for harm reduction. In our monitoring work over the past 15 years, the amount invested and the number of donors investing has reduced, so this gap is widening. The Global Fund is the largest donor for harm reduction in lower middle income countries, providing at least 60% of all donor support. In many countries, the Global Fund has been responsible for the introduction of harm reduction and is sometimes the only funding source supporting these life-saving programs. But it's also a rare source of funding for advocacy, legal and policy reform, and community-led initiatives, coming from what the Global Fund calls its catalytic investments. Given this reliance on the Global Fund, harm reduction advocates have joined the calls for a strong replenishment of at least $18 billion US. Despite raising more than ever before at 15.7 billion, the target wasn't reached. But even if it had been, the country level advocacy to ensure that harm reduction featured in funding requests would still have been required. So we're here to discuss what the replenishment outcome means for harm reduction and to share strategies on what we can all do to support harm reduction being funded. As the speakers share their insights, please put your questions in the chat and comments in the chat, and we'll pick these up in the Q&A section after the panel. We'll also be sharing some useful links as we go along. And just a reminder to mute if you're not speaking. So I will stop sharing my screen. And without further ado, introduce our first panelist. So welcome Robin Montgomery. Robin has worked on issues of HIV, TB, and global health for more than 20 years in the Canadian and international setting. She's also co-chair to the C7 Global Health Working Group, outgoing board member to the Developed Country NGO Delegation, and outgoing chair of the Implementer Group to the board of the Global Fund. So over to you, Robin. Thank you very much for being with us today.
Super. Can you hear me okay?
Yeah.
Terrific. All right. Well, thanks so much, Naomi. Thanks so much, Kat. Hi, everyone. It's really great to be here with you all today. And thanks so much to EHRA for hosting this really critical webinar. So over the next couple of slides, what I'm going to be doing today is highlighting rather quickly some of the key opportunities for harm reduction. And our other friends who are on today's call will help to fill out more of the details. So throughout the next 7 minutes, I'm going to run quickly through some of the details to set the context from the 7th replenishment outcome. And then I'm going to focus the bulk of the talk on the different opportunities that we see for harm reduction within NFM4. And then at the end, I'm going to leave with some of the key questions and reflections that have been raised during some key informant interviews and some research that Matahari Global has been doing together with HRI. So next slide, please. So this slide is not new to anyone. It helps to bring clarity. We see the new strategy bringing clarity to the contributory objectives. That we see resilient and sustainable systems for health has been expanded to include people-centered and integrated care. We see that pandemic preparedness or pandemic prevention preparedness and response remains an area of focus. But as we will see as we move through the different NFM4 modules and frameworks and documents, that it's largely part right now of RSSH. So under the NFM4, there is an additional focus on the country dialogue process and on community-led monitoring throughout the cycle. We see also in the strategy a renewed emphasis on the importance of health equity, gender equality, human rights, and on the sustainability of programming. And all of this is going to come out more throughout the rest of today's webinar. And of course, all of this is to help meet meet our goal to help countries meet national goals and our global goals and targets under the Global AIDS Strategy and of course the SDGs. Next slide, please. So as we've heard and we know, the replenishment outcome at the time of the November board meeting just a few weeks ago was about $15.7 billion US. $400 million at the board meeting was approved for catalytic investments, with funding in those catalytic investments for HIV multi-country grants, for strategic initiatives, for community engagement, and many others. But the real bulk of focus should be really on the $13.128 billion that was approved for country allocations. So if we look at the difference or compare it with the sixth replenishment outcome and what was allocated to country allocations under the sixth replenishment, we see that we have for the seventh replenishment a 3.3% increase. Now, this is a historic amount raised. That is absolutely true. And it's a result of our amazing advocacy efforts as a partnership. But as Naomi and Kat said, the reality is that we haven't reached the 18 billion and we still need a fully funded global fund. So can't underscore enough the importance of resource mobilization and continued civil society advocacy for a fully funded fund. Now, given the economic pressures that we are all experiencing around the world, most notably with rising inflation and very hectic currency exchange rates, this means that although we have a 3.3% increase for country allocations, we're actually looking at almost a flatline country allocation. So this means that more than ever, we need to ensure that each investment has the biggest impact. We know, and years of evidence show us, that harm reduction is a cost-effective, high-impact, evidence and right-based HIV prevention intervention that works. And it works not just for HIV, but for other diseases as well, including for TB. Next slide, please. And next slide. So what we have here is a timeline that's helpful to kind of guide us through the Global Fund application process for NFM4. So right now we find ourselves in Q2 of 2022. The yellow dot that you see at the top represents the replenishment conference, and the blue dots across the top represent the scheduled Global Fund board meetings, which are also important for advocacy. We see that we're currently in the last quarters of 2022, and that means that application materials for NFM4 have started to be published on the Global Fund websites beginning way back in July. And I believe, and Daniel will speak to it likely today, that even a new resource was released today on prison populations. So keep an eye out on this webpage weekly, if not daily, because new resources are coming out as we speak. The Global Fund's also started a series of webinars and has e-learning modules that are available up on its website. And I'll put the link to those in the chat box in a few minutes. We also see at the end of 2022 that allocation letters are going to be released by the end of this month. Window 1 submissions for funding requests is going to happen on March 20th. So within the next 3 months of 2023. Window 2 on May 29th. Window 3 will be on August 21st, and the remaining windows will be in 2024. Next slide, please. So opportunities within catalytic investments, of course, are really important and help to catalyze positive change within country allocations. It's often where we also find all of our funding, or most of our funding, for community and civil society interventions like harm reduction. But it's really the country allocation where we need to really focus. And there are key opportunities for harm reduction in community and civil society funding coming into the country allocations and in the various documents for the funding request. So here I just wanted to outline a couple. So in the RSSH modular framework, we will see specific opportunities for community and civil society to engage in social contracting, as well as the C19RM application process, which remains separate from the country allocation, but is to be folded together in an integrated way. The C19RM timeline has been expanded as per the last board meeting in November. So this allows more opportunity and greater focus on community interventions within the C19 funding mechanism. HIV program essentials are a new introduction into the NFM4. And what these are key evidence-based interventions and approaches that will help us get to those goals and targets outlined not only in the Global Fund strategy, but also in the Global AIDS strategy and the WHO Global Health Sector strategies on HIV, viral hepatitis, and STIs. In the funding request for this allocation period, applicants are now required to outline how advanced and how they're going to advance their country in the implementation of what's called a program essential. And there are 6 HIV program essentials. There's the HIV primary prevention program essential, and this is where we explicitly see harm reduction sitting as a program essential within HIV primary prevention. But it is also found across HIV testing and diagnosis, which is the 2nd, 3rd, elimination of vertical transmission, 4th, HIV treatment and care, the 5th is on TB and HIV, differentiated service delivery, and human rights. Another document that I really encourage folks to look at as you prepare for the funding funding requests is the TRP review criteria, which is found in Annex 1, page 15, of the terms of reference for the technical review panel. And I'll pop the link into the document or into the chat as well, but it's a really helpful document in terms of understanding exactly what the TRP is going to be looking for as it reviews the funding requests. There are also now a set of minimum expectations for community engagement, which is a new mechanism that's aimed at ensuring that community engagement remains above a certain threshold by setting clear guidelines for the proposal development process, but also for the grant making stage, as well as across the grant implementation cycle. And so here you'll find a couple of really important documents for our engagement, and this is represented in the country dialogue annex, as well as in the community annex. Next slide, please. All right, so here I wanted to run through a few tips to help ensure that funding for harm reduction is maximized. So as you can see from the slide, getting to know who is on your CCM and keeping in very close touch with them is going to be absolutely critical. So first, it's going to be really important to get in contact with the folks on the CCM and the CCM chair, including your civil society and key population representatives. This is going to be important to help confirm the submission window for your country grant. Important to stay connected to them because sometimes these dates do change. Also ask your CCMs, as well as your civil society and key pop reps, for their planned engagement roadmap that shows what the process is going to be, as well as the timelines to ensure meaningful community and civil society engagement. Importantly, CCMs in their funding envelope have 15% of their funds that is meant for constituency engagement. So there are funds there to support strong consultation in country to identify and prepare key funding priorities for community and civil society. The next, engage directly with your CCMs as well as your CS and KP reps, because these are the folks who are ultimately responsible and to be held accountable for ensuring inclusive and transparent country dialogue. Also, keep in touch with your in-country technical partners for any additional support. Now, a helpful strategy to prepare for the development of funding requests is often to work backwards from the submission date and to create an engagement plan as early as possible in your preparations. So with this in mind, try to begin your engagement now with diverse communities and drug user communities, especially those who may require additional support and time to really ensure their engagement in the funding request development. So this includes, obviously, all of our communities who live outside of city capitals. So discuss with other KPs, key populations, and community and civil society allies when and how to identify and build consensus across the constituency on the highest priorities and make sure to have them well costed. Now, there are lots of different resources. I know Daniel's going to speak to those in just a few minutes, but there are really helpful resources up on the Global Fund webpage for NFM4. Where direct engagement support might be needed or most needed, please also reach out to NAPUD for any additional support. There is also community engagement, strategic initiative, technical assistance available that you can reach out to. And I know some of our other speakers today will talk about how to do this. But I guess finally is we need to build our investment case, right? This means continuing to generate evidence to document our outcomes and our lessons learned from NFM3, as well as from the C19RM to help inform our priorities. And here it's going to be really important that we always make the link back to how it ties into the Global Fund strategy, especially the 10 key shifts in the Global Fund strategy, and how each of our interventions align with the HIV program essentials. Next slide, please. And then my final slide. So in some of this research that we've been doing together with Harm Reduction International, there have been 4 key kind of areas of reflection that I thought could leave our conversation, my conversation here today. So the first one that's come out of some of those conversations is around the program essentials and whether there are opportunities to meet these program essentials with a minimum percentage as a budgetary threshold in country grants. The second is around the community annex and how can we best leverage this both in country as community and civil society, but also within the Global Fund and technical partners to leverage this tool for ongoing community advocacy and engagement throughout the grant cycle. In terms of minimum requirements, here we've talked a lot about in our conversations that transparent and inclusive engagement with communities most impacted by AIDS, TB, and malaria really begins with access to the allocation letters. So we have been really pushing to ensure that those allocation letters are made public on the Global Fund website, together with a full complement of country grants across the country grant cycle. And then finally, building an investment case, of course, for comprehensive community-led harm reduction and harm reduction advocacy really comes down from the impact data from MFM3, and we will be doing our best to pull that together over the next couple of months and weeks. So with that, thank you very much. I will hand it over now to my colleagues on the panel. Thanks.
Thanks so much, Robin, for that brilliant overview. Just to mention that the consultation that Robin referred to, we will be publishing some of the findings from that consultation over in the next few weeks, maybe January is more likely. But yeah, we'll look forward to that. So handing over now to our colleagues from the Global Fund. We have Susie McLean, who is the lead advisor on HIV prevention for the Global Fund. She's part of the Global Fund's HIV team. Susie has 3 decades of experience as an HIV prevention and harm reduction programmer and an advocate in many different countries. And speaking alongside her today is Daniel Wolfe, who's the Senior Harm Reduction Consultant at Global Fund's Community Rights and Gender Department. And before this, many of you will know him as the former Director of Harm Reduction at the Open Society Foundations. Just to say that our translators are trying very hard to keep up with everybody today, so please remember to speak slowly. Over to you both. Thanks very much.
Thank you, Kat. Thank you, Robin. Thank you, Naomi. Hi, everybody. My name is Susie McLean. As Kat mentioned, I'm the HIV prevention lead, the Global Fund. I'm joined by my colleague, Daniel. We'll go into some slides in a minute, but I just wanted to say thanks to HRI for convening this discussion. And hello to friends and colleagues. It's great to see the list of names of people that are joining. Great to see lots of excellent friends and former colleagues. And yeah, Daniel and I are going to talk about some of the HIV prevention and harm reduction opportunities in the next cycle. But before, I was just typing it actually in the chat, but let me say it instead. A small but important detail, we're not using NFM4 anymore. The funding cycles are not new. So in fact, what the new parlance is for the next cycle is grant cycle 7, just so everyone's clear on that. I'm not sure, Daniel, do you want to say hi before we put the slides up?
No, why don't you just go and then I'll put the slides up a little bit later, but I know you, yeah.
Okay. So let me just say a couple of things by way of introduction. And Robin has helpfully already mentioned a couple of them, so I'll try not to repeat. But one of the things I wanted to kind of anchor some of our comments on was our new strategy. And I know that many of you made great contributions to the Global Fund strategy as it developed, and that it signals some new opportunities, but also some imperatives, I think, for how we work together as people interested in harm reduction. It's both, the way I'm thinking about it at the moment is that there are both new opportunities in the strategy, but also the strategy asks us all to do kind of quite a lot more. The first, you know, we've already heard from Robin around the kind of cross-cutting themes and stuff, but I wanted to bring people's attention to the HIV prevention objectives. The first one of which is to close the coverage gap. And I really think that I really kind of want to emphasize this, that one of the things that we've all together said is that we want to close the coverage gap for HIV prevention. In the context of people who use drugs and harm reduction, that means a lot more people should be getting HIV prevention services. A lot more people. Those of you who are familiar with the GPC scorecards, country by country, will be able to see that for people who use drugs plus other key populations, there are still vast gaps. The thing that we're trying to reckon with here is that there are still so many people who use drugs that are not getting any HIV prevention at all. And we're trying to do something about that. So this imperative around improving access to fundamental services is one of the things that is driving this work. The other sub-objective under HIV prevention that I wanted to refer to is the one that's around expanding service delivery options. So we know in harm reduction that the service delivery approaches are things like community-based, outreach-based services to get, for example, clean syringes to people, and that we also have this kind of common service delivery platform, which is the OST clinic. So one of the things that we're trying to advance here is that those two service delivery approaches expand and grow and can maintain, we continue to maintain our attention on them and we continue to invest in them, but that prevention needs to be available in a lot more places as well. So we signal, for example, pharmacies, online service delivery, sexual and reproductive health services. So I think it's an important question. I don't think we're going to have time, Naomi and Kat, to really go into that in depth, but maybe it's something that we want to talk about a bit further. But like, what are the other places and platforms where people who use drugs can get their hands on some prevention commodities? And or how do the current service delivery platforms that we have go further, reach more people. And then the other sub-objective in the prevention section of the strategy is around new technologies, new prevention options. In particular, I want to make reference to self-testing, to PrEP, what PrEP means for the opportunity of PrEP means for people who use drugs, injectors, stimulants, both. And also about virtual service delivery, you know, what does it mean for people who use drugs? So if we start from a premise of HIV prevention is changing and harm reduction is changing, new technologies represent new opportunities. What I think we need to be getting to swiftly is, what does this mean for harm reduction? Can we reach more people? Can we offer them a wider range of options? For example, self-tests. And we'll get to hepatitis C. So anyway, I think we should go now, Daniel, to the slides, but I just wanted to, of course, as Robin's already signaled, there are many other elements of our strategy and of our instruments and tools that are very relevant for drug users, notably the TB instruments, tools, guidance, but also all the work that's around human rights, community engagement stuff. Obviously, these are all really important, but kind of my specialty, or the thing that I want to focus on today is that there are big opportunities, big attention to HIV prevention, and that should bring some new opportunities for people who use drugs, or to expand the kind of access to services for people who use drugs. So as Robin's already mentioned, I think there's a real opportunity in the program essentials work. They exist for all of the key areas in HIV service delivery, so HIV prevention, testing, treatment, and HIV and human rights. And I don't think we've got a slide on the prevention program essentials, but it includes, I mean, some of them are really, I mean, there's kind of no surprises in there, right? They're very obvious to people who work in HIV program, but they include condom and lubricant programming, PrEP programming. And we also have a program essential that says people who use drugs have access to harm reduction. As straightforward as that is to say that people who use drugs or people who need prevention have got access to condoms, as straightforward as that is, I think we all know that many people don't have access to those program essentials, those fundamentals, condoms, PrEP, harm reduction services. And so one of the things that we're wanting to say here is that these are the foundations of HIV prevention. They should be in place. This is in our dialogue with countries and country stakeholders, CCMs. Where they're not in place, what can the Global Fund do to expand access to the fundamentals? And then in some cases, domestic resources will be funding them. In some cases, US government or other donor resources should be funding them. This is not saying that the Global Fund needs to fund all program essentials, but we are saying, and this is new, where the fundamentals are not in place, what's the plan that we'll see in the funding request? So I kind of say to you that the program essentials, in particular the harm reduction one, but also the other prevention related ones, and also the other TB ones, and also the human rights program essentials, I would say to you as advocates, these are a new tool that you have to make the case for the fundamentals to be in place. That fundamentals on harm reduction are available for all people who use drugs. So if people want to do so, we can talk more about how one might use program essentials in, for example, advocacy for better resources for harm reduction. I'm going to hand over to Daniel in a minute, but just before I do so, I just wanted to flag that there's this other thing that sits underneath all of this. Robin has alluded to it in her introductory remarks about it was a successful replenishment, particularly in the world in which we're living right now. But it wasn't, we didn't reach the target. And at the moment in the Secretariat, we're really kind of struggling with the realities of what that means, to set an aspiration that's quite high, but to not have all the full range of resources needed to do so. And I've been thinking a lot about what that means in terms of harm reduction programming and prevention more generally. And one of the things that we do know is that there's well, we don't know yet how much we'll be investing in HIV prevention. Countries will decide as they prioritize or not prioritize HIV prevention in their funding requests. But, you know, we can also kind of work from a presumption that there may not be vast new resources for harm reduction from the Global Fund. For example, given that the Global Fund is such a prominent funder for harm reduction, obviously, I think we can all see that that's a really important reality new reality that we need to work within. And one of the things that suggests to us is this issue about efficiencies, the need to reach more people with broadly similar levels of resources. So that's one of the things I really think that we could have a much longer conversation if there's time today or separately. But I want to draw attention in particular to OST provision for two reasons. We know that the service delivery costs for OST are really high. So if we want to reach more people with OST services, that suggests, and there aren't vast new resources available, that suggests for me we're going to have to work with country actors to bring greater efficiencies to OST service delivery. We also know that because of COVID, and interesting in the case of Ukraine, because of the war, that the costs of service delivery for OST have reduced just because they've had to. So daily attendance at a clinic, which costs a lot in terms of people's lives, costs a lot in terms of staff and premises costs and stuff. But because of these pressures on that very heavy service delivery approach, resource-intensive service delivery approach, new ways of getting OST to people have been developed in many countries. And I just kind of want to end by saying that's an important development, that there is opportunity there to say, to free up more resources for OSTs so that more people can get access to OST. One of the solutions may be in having lower cost, lower threshold service delivery approaches that ultimately I think would serve drug users much better. Over to you, Daniel.
Sure. Can people hear me okay? And can you also see my screen? Or
yeah.
Okay, good. So I'll be very brief because I know time is short, and we can share the full slide deck later, but I really just want to zero in on two key slides. So as both of our previous speakers have mentioned, harm reduction is now a program essential. But just to really underscore, and I'm very glad to see that we have TRP members also on the call, this means that all countries are expected in their funding requests to describe the status of and progress toward achieving this program essential. And if you're in a so-called portfolio that's a high impact or core country, you're expected to plan to implement it fully. And the priorities for harm reduction, not surprisingly to anyone on the call, are needle and syringe programming, opioid substitution therapy, and naloxone. But I just really want to underscore that because in many countries, harm reduction doesn't appear in the application or isn't sort of addressed seriously. So that is a change. Some other key changes for what formerly known as NFM4, Grand Cycle 7. One is that there is in the modular framework and in the framework more generally used for budgeting and planning, space for people who use drugs. Like the terminology has changed. We go back and forth, and people who inject drugs are still the priority and the key population, but people who use drugs and their sexual partners are also people who can be budgeted for in the HIV prevention programming. So that provides some new scope for stimulants work, for chemsex work. I know that it comes up often, and Susie mentioned PrEP, for example. I think we'll come back to it, but just really want to flag for you that people who use drugs is now a phrase, and Susie and colleagues on the prevention team worked quite hard to make that new space. So please take advantage of it in your applications. Another piece, Robin mentioned that human rights is a program essential. And in particular, there are 4 areas of human rights protection or removing barriers related to human rights for HIV services that are also expected to be addressed. One is making human rights protections integral into HIV and TB services. So for example, when Susie talked about making services more available, we're also talking about human rights services. Like what does it mean to put legal support, for example, in a drop-in center that's also distributing needles and syringes or providing people with HIV testing support. Removing stigma in healthcare, increasing access to justice. In many countries, access to a lawyer or a paralegal or keeping people out of prison or pretrial detention or police lockup may be critical to the success of HIV prevention. And this human rights program essential recognizes that. And then finally, advocacy, including, and this is particular wording, including community-led advocacy to reform harmful laws, policies, and practices. So all of these things, and I'm speaking to all those of you on the TRP too, like the idea is that countries need to have grappled with these realities in their application and to include, you know, a status report and plans for progress. And finally, Susie mentioned hepatitis, and I know that we have colleagues from CHI on the call, etc. I really want to underscore something very important, which is we've had many back and forths in previous years. What can the Global Fund support with regard to hepatitis B and C diagnosis and treatment? Do you need to be co-infected? And basically, the guidance is clear this year that people can be supported, people who inject drugs can be supported for treatment for hepatitis, regardless of their HIV status. That doesn't mean, of course, you need to make a strong epidemiological and investment case, as Robin was discussing. But I just want to be really clear that this is something that is not, there is now space in the application to achieve. I guess I would just end, because I know we need to go on and we'll come back in Q&A, but really to pick up a point that Susie made, and I think Robin made, but I really want to bring it home to harm reduction about strengthening the case and the link between community leadership, engagement, rights protection, and HIV outcomes. And I say this with great respect, and as someone who has myself advanced a lot of human rights arguments around harm reduction, but in this era of limited resources, and in this moment of replenishment shortfall, and in this time when we don't want harm reduction and human rights to just be split off and be something that's either above allocation or only funded through catalytic funding, it's really important for all of us to remind people, including on the CCM and the people putting together the applications, of the concrete links between why these things are program essentials and how it impacts HIV. So for example, if you are a network of people who use drugs in a country, rather than simply just saying, you know, we need a place at the table, we're a key population, we have a voice, make sure to remind the people putting together the application that if you don't talk to us, you may end up doing things like buying the wrong needles, which no one wants to use, and wasting resources. Or if you don't talk to us, you may have outreach programs that actually people will be scared to engage with. So really making it concrete that actually meaningful engagement is equivalent to programs that work. Similarly, when you're talking about things like police violence or harassment or arrest, it's not just that those things are rights violations, but it's also the case. For example, I was looking at some data from women in Indonesia that colleagues did, and actually I think some of them may be on the call. But for example, women who use drugs who've experienced police harassment are significantly less likely to use needle and syringe programming. And in the case of Indonesia, 79% of them who had been incarcerated experienced ART interruption. So these are very concrete links between the human rights program essentials and the HIV outcomes that Susie was mentioning that we want to achieve. You know, Susie mentioned OST and the incredible costs that are sometimes associated with it, at least incredible relative to other interventions. Well, it's so expensive in part because there's hardly any take-homes. Like take-home doses of OST increase patient flexibility, increase people's freedom to live their lives, but also decrease unit costs and improve efficiency. So really, as we move forward, whenever you can, as you find yourself making the arguments about the importance of community engagement and advocacy, and they are important, please try to make the link with the HIV outcomes that the Global Fund staff really are on the hook to deliver on, and that donors to the Global Fund are looking at constantly and saying like, okay, that's fine, but tell me how this relates to reducing HIV infections or improving diagnosis and treatment. So I will stop there, but because I know that Ganna and colleagues will talk a little bit more about technical assistance, but just to say that the lessons of the last funding round, assistance on costing and assistance on community engagement are all part of the technical assistance package that my colleagues at CRG can help to facilitate, and where there are regional technical assistance hubs. And I know Ganna is one, so represents one, so she can talk about that. Over for now, and I'm going to stop sharing my screen.
Thanks so much, Daniel and Susie. Some amazing insights there and some really helpful tips and information for the grant cycle 7 applications. So now moving on to Francis Joseph, who is the regional coordinator for the network of Asian people who use drugs, otherwise known as NAPUD. Francis is a drug user activist who's been working on the health and human rights of people who use drugs in the Asian region for almost 2 decades. We're really happy to have you here today, Francis. Over to you.
Thank you, Catherine and Naomi and the Harm Reduction International team for having me here to speak on behalf of the Asia, people who use drugs in Asia. The Global Fund is the largest source of funding for harm reduction in Asia, as in other regions. While only a few countries have begun investing in their harm reduction responses, more than 50% of countries in Asia that fall in the low and middle income category are heavily reliant on these funds to support harm reduction programs. Asia and the Pacific are home to the most vibrant communities that have a proven track record for implementation of successful life-saving interventions and have demonstrated numerous successful community-led models in the recent years. We have played a crucial role in maximizing A, people-centered integrated health services, B, the engagement and leadership of PUD communities to leave no one behind, and C, health equity and human rights. Global Fund funding is an essential source of support for harm reduction advocacy, legal and policy reform, and supporting community-led responses in Asia. Given that the new Global Fund strategy and the Global AIDS strategy emphasize community-led responses, the NFM4 grant cycle is an important opportunity for accessing funding to support community leadership in all aspects of program implementation, advocacy at the local, national, and regional levels and monitoring. As the regional network of people who use drugs, all our advocacy efforts are led by people who use drugs, and we advocate to ensure that appropriate people-centered services are offered to all people who use drugs living in the Asian region. Our core advocacy efforts are strive towards creating the 30-60-80 model of community-led responses and working towards achieving the 10-10-10 targets, to call on Asian governments to repeal punitive laws and policies that targets at us and advocate for policy reform. We envisage the implementation of supportive laws and policies that combat stigma, discrimination, and decision that influence our lives. We should be in the epicenter of all decision-making and abide by the nothing for us, without us principle. Our implementation experience in Asia has informed us that not all countries have meaningful involvement of people who use drugs at the harm reduction policy decision-making level, and we lack adequate representation at the CCM. Only a few countries in South Asia, such as Bangladesh, India, Indonesia, Nepal, have representation at the CCM level. Not long ago, the Global Fund had implemented the key population research and advocacy project, shortly named as KPRA, with the inclusion of all regional KP networks who were commissioned to conduct a 3-year research on the quality and mechanisms of country-level HIV services. A community-based quality monitoring study was carried out to understand the quality of harm reduction, including HIV services, and the level of satisfaction of end users of these services. The 3-year project ended with the research studies, and the findings did not come to any use of the Global Fund, as under the KPRA, under the Key Population Research and Advocacy Project, only research was done, but unfortunately no advocacy took place. Very few countries support Global Fund financing for harm reduction, and not all countries are fully funded and support harm reduction. Countries that are receiving Global Fund support do not have specific funding allocation to respond to people who inject drugs-led HIV epidemic. It is evidence that stimulant drugs are widely used amongst key population groups, and there are no mechanisms in place yet to address the drug use among SOGI-esque groups, where Chem6 practices are fueling the HIV epidemic. ATS and NPS have seen a steep rise in the Asian region, adding another threat to the health and human rights of people who use stimulant drugs. The war on drugs, which otherwise in reality is a war on drug users, still prevails in the region, and there are fewer commitments towards implementation of harm reduction services that can ensure the prevention of HIV, viral hepatitis, overdose amongst people who use or inject any form of drugs. There have been studies commissioned by the Global Fund to generate evidence on community-led responses, but we do not have sufficient papers that provides tangible recommendations on the action to be taken for harm reduction. Although 1 in 3 people who use drugs are women, only 1 in 5 women access treatment. Women who inject drugs face higher risks of contracting HIV and stigma. It is therefore critical to ensure access to harm reduction services tailored to the needs of women, as there are lesser or no specific harm reduction services for women. NAPUD has been exploring possibilities of multi-country grants in partnership with other Asian regional networks as a joint consortium with a focus on community-led monitoring. The replenishment has been shot by around $3 billion USD, which can impart allocation of new grants, which can impact allocation of new grants. The regional multi-country grants has to be in countries where CLM work doesn't exist, or with a very small allocation that leaves no room for CLM. We are in the process of doing a mapping with our national networks, whether or not CLM has been implemented or initiated in their countries. As most of the work under CLM is to be done at the national level, a regional proposal would have to be well justified, including the role of regional networks with a strong and filling gap in countries where CLM work is not happening. Another greater challenge that comes in when committed organizations that have the willingness to work within the communities, but do not have adequate financial capacities and requisite supporting documentation, and hence they're not considered as SRs or SSRs. Given that still, use of drugs is criminalized in many countries in Asia, support from funding agencies such as the Global Fund and technical partners such as UNAIDS is crucial. We believe in the country ownership model of the Global Fund, but the same model can put criminalized populations at high risk of marginalization during funding allocation and programmatic prioritization. We are glad that finally harm reduction is a program essential put forward by the WHO new guideline on key population. So we take it as an opportunity to prioritize harm reduction and people who use drugs-related interventions in the upcoming NFM. With this, we urge Global Fund, UNAIDS, and other funding agencies and technical partners to ensure that harm reduction as the program essential gets translated into increased funding and programs for harm reduction in countries. To disseminate clearer and louder messages to the decision makers that harm reduction is cost-effective to avert new HIV infections and save lives. To prioritize TA support to support the PUD engagement in the NFM4. To join forces with us to create enabling legal policy environment for people who use drugs, to build capacity and sustainability of regional networks and state-level networks, and to support established mechanisms to ensure that community leaders are involved in evaluation, review, and planning processes for PUD programs. I end it here. And thank you, HRI, for giving me and NAPUD the opportunity to speak. Thank you.
Thank you, Francis. We're so glad you could make it today. Some really, really important reflections there and reminders of the importance of people who use drugs being included in all aspects of the processes and the funding. Moving on swiftly to UNAIDS, we have Iris Semini, who is the manager of country and regional impact in the equitable financing practice, joining us today. In her role, she coordinates and guides technical support agenda and engagement with the regional support teams and countries on strategic investments and sustainable financing. Over to you, Iris.
Thanks very much, and thank you to Harm Reduction International colleagues and others for making us part of this webinar, which is very much needed. And I agree with Susie and other colleagues, maybe we'll need follow-up discussion on some of the topics that are emerging during our discussion. So I'll be a bit of an outlier, similar to my previous colleague, without slides. I wanted to go through a few priority ideas and suggestions, how we can support integrating effectively harm reduction programs in the upcoming global fund cycle, but also looking a bit more at the bigger picture, how we make the case, right, as many of you said. And the second point that I wanted to highlight is the type of technical support that UNAIDS has made available and provided at country and regional level in preparation for the global fund country application. So first of all, to say that you all have seen the UNAIDS report that was launched. The funding situation is, the funding falls short by $8 billion of what is needed to achieve the 2025 targets. And this funding gap is even bigger for programs for key populations. The situation is even more delicate, more dire, because 60 to 70% of new infections are among key population and their sexual partners, but the funding gap is bigger for key population programs for key populations and reaching out those in need. So UNAIDS has estimated that in order to meet the funding needs for key population programs, we need a 25% increase by 2025. Now, this is happening, this needs is happening against a very challenging international financial situation. We have the impact of COVID-19, which continues in particular in low and middle income countries, the impact of war in Ukraine, the high inflation, the increase of food prices, and on top of it, we have a debt crisis which is increasing, particularly for low income countries. This means that the expectations that we would have from countries to increase domestic resources are challenged, and countries are facing very, very difficult choices and context of fiscal constraints where the prioritization is going to be even harder than before. This is to say that as we try to make the case for investing in key population programs and harm reduction, our evidence needs to be extremely strong and well documented to show what is the value of the money in terms of impact that we are contributing to our HIV investment in HIV programs. In terms of harm reduction programs, we know it works. We know it is effective. It has been proven in countries, in high-income countries, that we can even reach a point where we have reached the transmission epidemic control among people who inject drugs. What's lacking in the other countries, it shows that is insufficient coverage of programs, which many said, ineffective choice of interventions. Needle and syringe programs are not, interventions are not to scale, OST is not to scale. In prison settings, there has been some reduction of programs. So we have the tools, we have the methods, but we don't have the scale. And the scale is partially due to funding, partially due to policy decisions and costs, right? So I think as we envisage and as we engage at country level to prioritize what a programmatic package for harm reduction should go for investment under the Global Fund resources, we need to keep in mind and have a holistic approach, which looks at how the harm reduction programs, what is the combination that would give us the highest impact, not only through the Global Fund resources, but at a national level. And this is one of the requirements of the Global Fund, right? In terms of funding, we need to show impact at the national strategic plans, well-costed, well-budgeted, effective, efficient strategic plans, which then will guide the choice of intervention in the Global Fund resources. So one is making the investment case in terms of epidemic impact by programmatic package and contribution to reducing new HIV infection. We have the arguments. The HIV infections are the ones, the decline of HIV infections, new HIV infection is far from what our ambition is, right? So how do we show the impact of harm reduction program contributing to that larger impact of HIV prevention programs is very important. And for this, there are tools and technical support that we are providing in countries jointly with Global Fund and the networks, like the modeling impact and using the updated costing method. The second point, which is very important, is to make the economic case. And in the current fiscal situation, we need to put forward what is the cost of every new HIV infection that we are not able to control. One is people being infected, but the other one, we know that for every new HIV infection, the cost, the life managing cost ranges from 5,000 to 500,000 if we take a societal impact. And this is not only for harm reduction, right? This is for every new HIV infection. So bringing that evidence in our argument would also make the case for reaching towards those who make the fiscal decisions. And in this environment that is very challenging, it is important that the health and social impact is along with the economic impact. It is clear that every new infection now, it has a long-term, at least 30 to 40 years commitment on health budgets. And that is something that the ministers of health and others need to be aware that investing now will release much needed resources in the future for other health spending and priorities. So along with health impact and epidemic impact, we need to make the case for the economic impact as well in the current fiscal situation. The third point that we wanted to bring forward is, as we make the case for the choices of interventions, we know that with financing, how it is allocated and how is it spent matters. So it's not only about the funding amount, but it's also how it's spent and allocated. And I think Susie was raising it as another colleague. It's a very important point to look at the delivery modalities, and community-led harm reduction programs have been proven to be the most effective way of achieving our targets. It's not only about efficiency. We should avoid to think of community-led response as the less costly one. No, it's the most effective one, without which we will have many new infections. But the community-led response, first, is not funded to the level that we need to have a population level impact. Second, we also don't know the cost most of the time. So what UNAIDS is doing now is working with many civil society and community organizations to put in place methods which help community-led response assess the cost and the budget in a way that includes fair pay, in a way that estimates the resources that are required and the budget needs to implement an impactful response. So one is about looking at the models of delivery and how can we make the delivery more effective, but also more efficient. The other one is also to make sure that we provide technical support to community organizations to estimate the budgetary needs to fully reflect the cost of the programs for implementation. So a big focus from UNAIDS perspective and from our priority in terms of technical support is to support community organizations to participate not only at the level of CCM and policy and financing dialogue, but also the technical input that they require to put together robust interventions for and contribution to the Global Fund country application. In terms of efficiency, I think there is what we wanted to highlight from UNAIDS perspective is that during COVID response, with the community-led response showed that how important the platforms that were established for HIV were for implementing the COVID-19 and reaching people who are vulnerable. So making the case that the community-led response has benefit beyond HIV is another strong argument in the Global Fund country applications, because we are reaching people who are in need, who are left behind, not only for HIV, right? Stigma and marginalization affects key population beyond HIV. So this is another strong point that can help make the argument. The additional component, and I want to build on what Susie was saying and Daniel was saying, we look at unit cost and those become prohibitive on what we put in our program applications. We need to further investigate, and UNAIDS and other colleagues can provide technical support to further investigate what is driving those unit costs. If it's a policy issue, then, and the community organization know that best, then we need to put this evidence on the table how that policy change can bring a reduction on unit cost and make OST less expensive. We have seen this in Ukraine when OST was being accompanied with security services because it was not legal. The cost was very high. So again, during COVID, these new interventions that were put in place where OST was taken home and facilitating access, we need to identify those innovative ideas that has brought larger scale of programs and change and advocate for policy change. So from our UNAIDS perspective will be also that donors do not fund only service delivery, but also fund requirements and requests from CSOs for advocacy, for policy change, and for better understanding the cost drivers. My last point is about enabling CSOs to drive also the change in laws and regulation and criminalization. And there is the evidence. It's not only about supporting and addressing inequalities. We have the evidence where it shows that where people are criminalized, whether it be sex workers or drug users, then there is a lower level of viral load suppression, higher level of infection spread. So bringing the evidence to the arguments about removing structural barriers, which is a priority for human rights programs and for UNAIDS, it's also an important component. Always thinking that we are there will be tough discussions at country level, right? In terms of priority setting. So the stronger the evidence for every point that we bring forward, even if it's in the program essentials, the stronger the chances that we're gonna obtain the resources to expand the harm reduction programs. I wanted to conclude by saying that the more important element, at least because I work in equitable financing as well, so for us it's critical, is what we call social contracting. And I wanted to put on the table a broader concept that social contracting is integrating CSOs in the national systems of delivery, including in the strategic purchasing and universal health coverage discussions, and also in the financial instruments. So the CSO-led response, or the CSOs, are capable and also legally allowed to receive public funding. So they are a partner in the health systems, but also access other funding without legal repercussion, like the previous colleague was saying, without putting them at risk, right? So they can have the access to mobilize other resources where public financing does not remain the only funding source, in particular where we have political economies that do not allow. So the World Bank estimates that at least 1 in every 3 countries, 2 in every 3 countries will not have the domestic funding required to invest in health because of the financial crisis. But this doesn't preclude us from making the legal and regulatory changes to make CSO part of the systems. And it's very encouraging to note that the global fund requirements for health system strengthening do acknowledge and encourage countries to put in place requests for establishing social contracting in countries. So this is another opportunity that we have. We know it's a process that takes a lot of time. It doesn't happen over the year. So I think it's an opportunity to integrate this in the request. From the UNAIDS point of view, many of you know that the UNAIDS technical support mechanism is quite proactive and available to provide technical support to countries to develop the global fund, country applications, cost of community-led response, and more importantly, the UNAIDS country offices are the platform that can facilitate the participation in a meaningful manner at the regional and country level in partnership all together. So I'll stop here and thank you for this opportunity and looking forward to the follow-up steps and discussions as well. Over.
Thanks so much, Iris. Yeah, it's becoming clear that one webinar is not enough for this big topic. Yeah, thank you so much for providing the UNAIDS perspective there. So over to our last speaker, Ganna Dovbakh, who is the Executive Director for Eurasian Harm Reduction Association, who work towards progressive human rights-based drug policy, sustainable funding, advocacy, and quality of harm reduction services for people who use drugs. Over to you, Ganna.
I hope you could hear me and see my slides. And I will try to be fast. Actually, I'm here in 2 hats, and I start with the main as a harm reduction association to share some key elements which we are thinking when we are thinking about new global fund and harm reduction. And first of all, we are thinking about situation when the crisis become new norm for the Eastern Europe and Central Asia. In addition to COVID, we now have Russian war against Ukraine, which caused millions of people lost their homes, left their usual circumstances, left within Ukraine and abroad, and it's millions of people who really went to the countries, neighboring country, not only Europe, but also Caucasus countries, Central Asia, left they came to countries where the harm reduction funding and harm reduction sustainability is under the big question, as Southeast Europe, as even Poland, Bulgaria, Moldova. So all these countries are doing and supporting people from key populations, refugees from war, with the volunteer resources. And actually we as a regional networks united to think over how we are dealing with the war, and I'm giving the link to the communique from regional consortium, which is important for us, and thanks to UNAIDS technical support mechanism we had the opportunity to reflect what will be changing, and even to provide global fund with the key recommendations on this emergency. And I need to thank all the harm reduction family, let's say, or community for your supporting, even with this small resources which goes directly through our crowdfunding campaign to the people to evacuate. So with this crisis, we see how important was response from Global Fund emergency response with the procurement, but also response of key population organizations, community organizations and harm reductionists. We all, like all community organization in Moldova, Ukraine, Poland, and mainly in Ukraine, they become shelters. And now we already start thinking together with the Global Fund multi-country project, which is SOS project, we start thinking about emergency package of services. And that's why we are saying about back to the, forward to the roots of harm reduction. And we all remember that harm reduction, it's not only HIV prevention for people using drugs. It's basically housing, food, basic medicine, and all humanitarian support if people need it. And in case of Ukraine, it's also evacuation cost generators, mental health support in the case of gender-based violence in emergencies. And that's huge amount of money. And what we are doing together with the other partners, we are connecting Global Fund program, which could support part of it connected with HIV TB response and other humanitarian response. And it's a huge work of our partners in Ukraine. And we hope that that could be supported further on. So again, about the gender focus, there was in chat comments from Robin Gorna, and I need to emphasize that what we do have, what we now see, that country level stakeholders, medical doctors, ministries of health, they know a lot about RT treatment and procurement, but what they need to learn now from us as a community experts, from regional networks who gain a lot of experience, they need to learn new essential words, essential knowledge on the gender equality, on the gender sensitive and gender transformative services, as well as the broad understanding of human rights and all this, like we are saying essentials and we have them in strategy, but they never been addressed as a center of the proposal. And that's very important advocacy. We already started with the countries saying I am saying about the national communities, members of CCMs, as well as regional networks who are supporting them with the technical knowledge. And I need to say that thanks to the, for example, Elton John AIDS funds and Robert Carr Network Fund and PEPFAR investment and technical expertise and support from UNFPA and UNODC, we have plenty of knowledge and pilots of this intervention, which we are now listing for our region, which could be included in the national proposals, which already existed or exist and implemented in some countries, and we need to have them in majority of countries because of the change in drug scene, because of change needs of the people. And among them, it's a package for non-injecting drug users, package for stimulant drug users, drug checking. It's already exists even through the Global Fund support. You will be surprised. OST, take-home dosages, different drugs, mental health services, integration with the harm reduction, legal and paralegal support, which we already piloted in multiple countries in the region. That's possible, and that's absolutely like already existing capacities from in the community. Drop-in center, safe consumption room, needles and syringe vending machines, gender transformative services, different kinds, peer online counseling, shelters for survivors of gender-based violence, maybe not very specific, but linkage to existing shelters, community-led monitoring of services, but in addition to this, community-led monitoring of impact of stigma on quality of life, and monitoring monitoring of services, not only health services, but social services as well, because majority of harm reduction sitting in the municipal funding for on social services for women, children, teenagers. So I will be fast, and I am saying that all these resources available for our communities, and we are planning, and I hope that in other regions, regional and national networks of harm reduction and community of people even using drugs also will make available all resources, all information about pilots to help communities to include. Not a lot of like description in the proposal is very short. Justification for this interventions exist in a lot of international documents, not only Global Fund, but also I need to emphasize UNODC and UNFPA could become the key technical agencies for a lot of these interventions. And now I will move to the my other hat. That's Eurasian Harm Reduction Association is host for Eurasian, for Eastern Europe and Central Asia platform, CRG platform, under the Community Engagement Strategic Initiative. And I need to say that there are plenty of resources. It's really additional resources also available for providing technical support to support CRG, it's community rights and gender. So community rights and gender related assessments, program review, community consultation, organizing community consultation, coordinating input into the proposal. So community could ask for the technical support to have proper consultant, English-speaking consultant, which is important for non-English-speaking regions, who will help you to formulate in a proper language parts in the proposal to be supported. Also costing support. That's the tracks for the technical support, which is important to apply. With the timeline, there is the big urgency in the timeline because actually this program is rather fast, and we are doing our best to make it fast, but you need to have at least 4 months before the TA provision to formulate the application, to find proper consultant, to make the logistics. So please be fast. If you are applying even for the second window, you need to apply for this technical support as soon as possible to have resources to support community level dialogue, or community to support community in writing some parts of the proposal. And that's actually what we are recommending to steps to take. You need to select what track you need to choose, and then you are making the application. In case of our platform, we have specialists, and if you will write to us or to me directly, or to Ivan Verentsov, who is coordinating this work, you will get support in formulating this request to make it faster. So that's all available, and we are trying to do our best for involving communities in all these processes. Thank you.
Thanks, Ganna. That's really useful to hear how it's all working in the EHRA region. We're running slightly over time, I'm afraid, so our Q&A section is going to have to be saved until the next webinar. But I did want to just bring in our colleagues from CHAI, who have agreed to just share a very brief introduction to their toolkit on hepatitis in the new grant cycle and how to include it. So Craig.
Thanks, Kat. Thanks so much, Kat. And very quickly, first, just to say it's so fantastic to see so many dear friends and colleagues from around the world, and even a couple of other funders. I see Tom from Elton John AIDS Foundation. I see Olga from the Robert Carr Fund. So really terrific. Thank you, HRI and community partners, for organizing the event. just wanted to say that CHAI and many partners in the hepatitis, HIV, and harm reduction communities have encouraged Global Fund over many years to expand eligibility for investments in viral hepatitis elimination as a critical element of efforts to end AIDS. And it has evolved over time. As Daniel and Susie alluded to earlier, Grant Cycle 7 is the first explicit opportunity for countries to secure Global Fund resources for hepatitis B and hepatitis C commodities and programming support beyond HIV co-infection. And explicitly in the HIV information note that Susie referred to, that allows for hepatitis B vaccination and hepatitis B testing and hepatitis C testing and treatment among people who inject drugs and prisoners, regardless of their HIV status, through HIV, sexual and reproductive health, and harm reduction services. And I should just also note that this also is the first time that Global Fund explicitly allows for HBV testing and prophylaxis through antenatal care services as part of efforts in countries for triple elimination of HIV, syphilis, and hepatitis B. So, you know, hepatitis services and commodities in combination with proven harm reduction interventions, especially opioid substitution therapy, naloxone, overdose prevention, and needle and exchange programs, in combination with hepatitis services really is as a program essential, can make a huge difference in the lives of people who inject drugs and of prisoners, but only if countries prioritize including requests in their submissions for use of their allocations. And I just want to ask my colleague Umesh Chawla, who has been the program lead in our India program and is now transitioning to be the Associate Director of the Global Hepatitis Program with key responsibilities around communities and key populations, to talk about a resource toolkit that CHAI has developed in partnership and consultation with other partners to help countries advocate for inclusion of hepatitis investments in their concept notes. Over to you, Umesh.
Thanks, Greg. I hope I'm audible.
You are.
Thank you. I am cognizant of the time and that we are running short, so I'll be very brief. The opportunity with regards to, supporting harm reduction services, including expansion of scope for hepatitis C services and hepatitis B services, can only be materialized if countries are able to actually utilize this opportunity and understand the guidance much better. So thereby, CHAI and along with its partner thought that we create a toolkit which is a ready reckoner of resources that can help not only countries, also regions to understand these opportunities and make best use of. And thereby, this particular toolkit, which will be available in a couple of weeks and widely disseminated, has a lot of resources that can actually be tapped into to understand the application processes, to understand the nuances of how different countries and different organizations actually propose to Global Fund for their requirements, and how prioritization documents are created in different countries, which are very diverse and contextual in nature. So this toolkit will provide quite a bit of information, as well as a lot of stuff that can help build the justification case, which was talked upon earlier. For example, the rationale of including hepatitis services or harm reduction services. What does the market look like? What is the different pricing of commodities? What is stopping these commodities to be made more accessible? So all this all in one document, which is going to be released in a couple of weeks. We hope to make this a live document, which continues to be enriched by the feedback that we get from the participants here and wherever it's going to be disseminated to. And very happy to receive any critical and productive feedback once this particular document is made available to all. So I tried to be as brief as possible. Happy to answer any questions. Please do email me or Craig, and we can set up a time to discuss this further. Thank you. Over to you, Craig.
Nothing more from me. Thank you so much for the opportunity, Kat.
Thank you, Umesh.
Catherine.
Thank you, Craig. brilliant to hear about the CHAI initiative. I'm gonna kind of close the webinar. I feel like we've had so much rich information and discussion from the panelists that it's such a shame that we didn't have Q&A today, but I didn't want to cut anybody short because they had so much useful things to talk about. But you'll be glad to know that we've recorded the webinar and it's also going to be made available in French, Spanish and Russian. I want to thank my colleagues Ruud, Suchi and Colleen for recording those translated versions and our really hardworking translators for making this possible. And thank you all to the participants and our wonderful speakers today. Really, really grateful that you could be with us to have this discussion. We will be arranging more webinars on this topic. So hope to see you again soon. Thank you very much, everybody.
Thank you.